So I'd like to introduce the next speaker is Professor Stephanie Watson. She will be talking about nailing down allergic conjunctivitis. Professor Watson is a cornea surgeon known for her groundbreaking research in cornea therapies. She leads the corneal research group at the University of Sydney and is currently the head of corneal unit at the Sydney Eye Hospital. She is the chair of the Australian Vision Research, and she's the only Australian to make the power list of the top 100 women in ophthalmology in 2021. And in 2022, the only Australian woman on the top 100 power list of all ophthalmologists. She has received Arvo Silver Fellowship, New Zealand Dorothy Potter Medal, and the New South Wales Premier Prize for Leadership in Innovation. Without further ado.
Thank you very much for the kind invitation to speak and for those kind words. I'm going to be talking on ocular allergies. Now, ocular allergies are hypersensitivity disorders, and understanding this helps with our management of the conditions. Because seasonal and perennial allergic conjunctivitis are both type 1 immediate reactions, and vernal and atopic keratoconjunctivitis are type 4, which is cell-mediated. Now, in type 1 hypersensitivity, there's high levels of locally produced IgE, and the disease can be easily reproduced by installation of the allergen. There's many mast cells and eosinophils. And so both these forms of allergic conjunctivitis tend to produce immediate symptoms, with seasonal being intermittent, happening according to the season as the name suggests, and perennial year-round. Both of them can be common, and they're mostly mild and not progressive, just producing their effects when there's an exposure to the allergen. The management, therefore, initially involves just trying to avoid the allergen. You need to try to figure out what it is. And this can be a little bit tricky because skin prick tests don't actually correlate always with what happens on the eye. And so sometimes it's taking a history. And one of the more common allergens can be house dust mite. And you can ask the patient, look, do your eyes get worse when you're at night and you're asleep? Because often the pillows and the bedding, and if there's carpet, contain a lot of dust mite. Cold compresses and lubricants, which can basically wash any allergens out of the tear film. Then you can move on to things like topical antihistamines and mast cell stabilizers, which are effective, but we don't really know about their effectiveness in the long term. Topical non-steroidals have been trialled, but you need to be very careful if the patient has any dry eye symptoms, as they can cause melt, and they can also produce irritation. Systemic antihistamines and mast cell stabilizers can be useful, particularly if the patient also has signs of things like hay fever or rhinitis. But type 4 hypersensitivity disorders require a bit more management. That's because they're mediated by cells, and these cells release more factors that cause greater damage to the ocular surface. Type 4 hypersensitivity is also associated with corneal graft rejection. And why do we worry about these conditions? Because both of them are a threat to the cornea and a threat to vision. Vernal occurs in children and atopic in adults. With vernal disease, it generally resolves in 2 to 10 years' time, and the children can be left with a good outcome, whereas atopic keratoconjunctivitis continues and is often severe and progressive. Fortunately, it is rare. This slide here tells you everything you need to know about who is affected by vernal keratoconjunctivitis, and it's typically young boys in hot and dry climates. That's my son getting hot there. Okay, so with atopic and vernal, why are they sight-threatening, and why do we need to manage them better? Well, there's a number of reasons why. One is the direct effects of the disease. 2, they create ocular surface disease. 3, they're associated with other diseases. And 4, treatment can also worsen the risk to sight. So what happens in corneal disease? Well, all the inflammatory mediators in the upper lid cause erosions on the cornea. These then join together to ulcerate, and in the long term you can get corneal scarring and neovascularization, with up to 10% of patients in vernal getting shield ulcers and around 1% ending up with limbal stem cell failure from both types of the disease. So this is what happens in a shield ulcer. You get sort of staining of the upper lid, which then leads to this macroerosion, which gets filled with debris and forms a plaque. And then even when you remove the plaque, you may be left with the ring scar. So the key to managing a shield ulcer is to control inflammation, because it's all the inflammatory mediators in the upper lid that are producing those erosions. You then need to get in there with lots of lubricants to prevent any mechanical trauma, and perhaps use a bandage contact lens. The plaque may often need to be debrided, and in some cases you can use amniotic membrane to promote healing, and people have tried PTK. Now, dry eye disease, we've just heard some lovely presentations on dry eye disease, and it's more common in these allergic diseases because of the inflammation, which over time also alters the mucin layer. There's been observations of meibomian gland dropout and reduced nerve sensitivity. The lids often end up thickened, and there's a reduced blink and lag ophthalmos. Keratoconus, as you probably know, has been associated with allergic eye disease, and it's thought to be exacerbated by the chronic rubbing that accompanies the allergic eye disease. And for people with allergic eye disease, keratoconus can occur at an earlier date. And if the patient does get a corneal graft, they're at increased risk of rejection, and a severe condition known as sclerokeratitis, which often requires systemic immunosuppression to treat. Patients with intrastomal rings and allergy can get increased risk of melts. Keratitis is more common with gram-positive organisms such as Staph aureus, including MRSA. And if patients with atopic or vernal disease get herpes simplex, it's more likely to be bilateral and recurrent. Now, we need to treat these conditions, but we also have to be mindful of the effects of treatment. And what can follow, particularly if steroids are used, is glaucoma. If preserved agents are used, you can get toxicity, and this is particularly the case with fortified antibiotics for keratitis. And the slide here with the staining shows conjunctival ulceration that's typical with gentamicin use. And the best way to pick this up is off the slit lamp by asking the patient to look up and down, and you'll see up the top the conjunctiva is white, where down below it's red. So how do we manage these type 4 conditions? Well, we need to suppress the T cells. Topical cyclosporin can be useful in doses like 1 or 2%. It can sting. Topical tacrolimus has also been trialled, but again there's risks of irritation, epithelial keratitis. There's been reports of herpes simplex and even raised pressure with tacrolimus. These images here show a patient treated with topical tacrolimus, initially induced with steroids, and the bottom slide is after 12 months. So topical steroids, you need to be mindful of which steroid you're using. And you want to start with low intraocular penetration steroids because the disease is really on the surface. And that's because these will have the least risk of raising the pressure and of causing cataract. You could then move on to higher potency steroids if needed. But remember, in vernal, up to a third can have raised pressure, and 6% can go on to develop glaucoma. Systemic immunosuppression may be needed in severe or recurrent disease, and this is decided with the physician. You need to monitor for side effects and consider immunotherapy, which in some patients has been shown to be effective. This slide has a bit of detail, but the main point here is just to mention dupilumab, because it has been said to be associated with allergic conjunctivitis or to cause it. When you look at the literature, the evidence on this is a little bit mixed, because some patients have already had the conjunctivitis before. But the point is that if you do have a patient on this therapy, you need to monitor them before and after to see whether the conjunctivitis has gotten worse. But in most cases, you can treat the conjunctivitis and continue with the treatment. There's a range of new biologics coming on the scene that you may soon see in the clinic. What about surgery? Well, subtarsal steroids can be considered, but they can increase the intraocular pressure, cause eyelid necrosis, fat atrophy, and excision of giant papillae has been considered. Corneal surgery also includes superficial keratectomy for shield ulcers, amniotic membranes, limbal stem cell transplantation, and Boston K-Pros in very severe cases. So lastly, managing ocular allergy. Avoid the allergen and try simple measures first, such as cold packs. First-line topical therapy is really antihistamines, decongestants, and mast cell stabilizers. Second-line is steroids and immunomodulars. Systemic therapy may be needed, and usually you do this with a physician. and surgery not needed often, but sometimes for non-healing shield ulcers. Thank you very much.
Thank you, Professor Watson.